All right. So sorry for the tardiness. Wait for Cola to come in. I'm all right. I'm tired. I just got out of surgery. Like I've been operating all day, so I'm tired. But otherwise, I'm good. Let's see where she at. But she got all the questions, so. She should be chiming in here in a second. She's unable to join. Here she go with her technical issues. Let me see. I'm gonna try it again. Hold up. Anyway, absolutely product of Dr. Norman Francis. What's up? What's up, Mil? All right. Well, I'll kick it off and we'll just wait for her to come in. Today has been a long day. I've had 2 major surgeries. This last one was like a myomectomy, and she had like, I don't know, probably at least 30 fibroids. I'm gonna post some stuff when I get a second. I appreciate that. I'm glad people are appreciative of me posting. I appreciate it. I do look tired because I am tired. Now you've been like standing over people, like cutting on folks all damn day. You get a little tired. Why Cole is unable to join, I have no idea. Y'all bear with me for a second. Let me try to DM her or something, because she has like a bunch of questions. She has some very, very good questions. She has some extremely good questions that I wanted to answer. She had like some really good questions I wanted to answer. I don't remember them all.
There we
go. Here you go with your technical. I'm trying to call the people.
No, it was definitely not me.
It is you. It is always you in electronics. Your electronic game it was getting better for a minute. Now we got to knock it back down.
Man, I said I requested you. It said you tried to chat call me. I pressed all the right buttons. And it wouldn't let me join.
That's all right. The people gonna tell you, they're gonna be like, we've been in here waiting on you for forever.
I'm sorry. I was watching, but it wouldn't let me
it wouldn't let you in. All right, let's get to it. I'm sorry for my tardiness. I literally just got out of surgery. Like now, I was trying to finish.
Oh wow. All right. Well, thank you.
So I'm gonna task you with like looking at all of the questions and stuff.
Yeah, as long as it'll let us see questions.
I'm reaching all the way to Ontario, Canada. Look at that. I actually had a consultation with a lady that came from that's going to come here from Canada. She's trying to work all of her stuff out now. But I got people calling from everywhere. It's just unfortunate, that there aren't, providers that do what I'm trying to do, like everywhere. Because it was crazy. Like somebody was arguing. Like I don't remember the girl's name. Some of these trolls, they be killing me. Like she was trying to argue with me about like UFEs and like you're opening people and you're doing these surgeries and you could just get UFEs. And I'm like, what? Like she was just arguing with me. From Alberta, Canada. I'm getting deep in Canada. That's what's up.
Wow.
Yeah.
That's
so
amazing.
I mean, literally the fiber. Like I took it. Like I just did the surgery on this girl today. Like literally, I just walked out of there 10 minutes ago, and she was just like she wanted me to video it. I videoed it and showed it. And she was just like, we were going over why laparoscopic myomectomies, like why I strayed away from it and why she needs UFEs or uterine fibroid embolizations. We'll get into that. And I was telling her, I was just like going over. We had already talked about it. But she was like, I've got 6 or 7 fibroids. I was like, look, I promise you, I have not been in your belly, but I promise you, you have more than 6 or 7 fibroids. Guaranteed. She got over 30 fibroids, like easy. I didn't even count them all, but it was like, and the last 2 or 3 fibroids were literally like booger size. Like, I mean, you could get the smallest booger. It's like literally that size. And I was feeling her uterus for an hour, literally just feeling. And actually, when I was closing it up, the last one I felt when I was actually almost done, and it was like the size of a quarter of a pea, and I pulled it out. So when you leave those, they come back. They'll come back. So you can't get that laparoscopically. So I stand on my assertion that laparoscopic myomectomy is just, unless you know that that person only has 1 or 2 dominant fibroids, it's just not. UFEs don't work. They don't. I just did a consult with a lady earlier today that's coming to me to get a hysterectomy, who had a UFE, who has been in pain, in dire pain, since she had it 2 years ago. And I'm gonna post that picture. I have actual intraoperative pictures from patients with UFE, so you could see what UFEs do to fibroids, right? Because me talking, people don't believe me, so I have to actually, you know, show people. So I'm going to show what a UFE fibroid looks like. They probably gonna block it because, you know, Instagram, Facebook, they just don't like anything of the body. But just click on the picture. I'm gonna do it. All right, I'm done running my mouth. Let's get to the questions.
No, we like to hear what you did for today. So
yeah, let's get to the questions.
All right, so Q&A.
All right.
How effective is the HPV vaccine? Is it only for cervical cancer? Because they are recommending my son get it as well.
Phenomenal question. So my son got it too. My son will be 15 in 2 weeks. I have twins. I have a boy and girl twin, and my son got both of my son and my daughter got HPV vaccine. So let's kind of break down what HPV vaccine is, right? So HPV is an extremely prevalent virus. Like, so there's like over 100 some odd, close to 200 some odd strands of HPV, right? Anytime you see a wart on somebody's finger or a skin tag, that's from HPV, right? So human papillomavirus, or HPV, typically cause warts. In women, HPV is the only virus that can cause an actual cancer, right? And it's not all forms of HPV. So don't think if you have a wart that is going to turn into cancer, right? What we know is that there are about 9 strains of HPV that are really, really harmful, and can be harmful for women as well as men. So they get into these mucosal surfaces, like on the cervix or in the throat or in a lot of other different places that have like mucosa or fine tissue, and they can cause those cells to become abnormal, and that abnormality can lead into a cancer. Just like any other vaccine, we're not about to get into the whole COVID thing or whatever, but just like any other freaking vaccine that exists, all you're doing is exposing the body to a variant or a similar molecule with similar components of the virus, so that your body can fight the virus and get rid of it. So typically, the body gets rid of HPV, right? For most women, the body will get rid of it. These 9 strands that I'm talking about, if a woman gets infected with one of those 9 strands, it can actually start the cells to become abnormal, and it can actually lead to a cancer. For boys or young boys, the reason why it's important, because they're vectors, right? Men are vectors of HPV, right? So when you have sex with a man, if you have abnormal strands of HPV, he can take that HPV virus and actually spread it to other women. In addition, now what we used to know is that, all right, well, it doesn't really, well, we used to think that it doesn't really affect boys or men, but now it does. Like, we've seen it start to cause anal cancers, throat cancers, right? So how do you get throat cancer? Use your brain, right? So if HPV is in the vagina, oral sex, you can get an HPV cultivation in the throat, and it can cause men to have oral cancer from HPV. So we know that those high risk strains are the problem. So that's why the vaccine is preventing infection from those high risk strains. So that's why it's important for males as well as females. If you have a son that is of age, ages 11 to 26, we are giving those vaccines. That's why my son has it. I highly recommend that you get your son and your daughter vaccinated for HPV vaccines.
All right.
Can doctors test males for HPV? The answer to that is really no, because we don't have a general area where HPV is problematic for men. So the reason why we could test it for women is because it's very prevalent and it can be problematic in the cervix. If y'all looked at my video last week when I talked about like colposcopies, the reason why HPV is such a problem is because in the vagina and the cervix, there are two different type of cells. I don't want to get too technical, but it's a squamous columnar cell, and it's another different type of cell. I'm forgetting the names, but these two different types of cells, like one cell in the cervix and one cells, the type of cells in the vagina, they interface because your cervix is right there where the vagina. Where that interface happens is called the transformation zone. And in that transformation zone, which is only like about a centimeter thick, that's where HPV attacks. And if HPV can attack and cause those cells to become abnormal, it can change into a cancer. When we do pap smears, that's the zone that we're testing. We're testing the cells in that area. The men don't have a transformation zone or anything that, you know, HPV likes to attack. So it's very hard to get to test for men or young boys for HPV.
All right, I'm gonna go back and forth from comments to submissions.
Okay.
So in the chat, do Nabothian cysts on the cervix block cervical cancer detection, and can you get rid of them naturally?
No. So Nabothian cysts do not block cervical cancer. They are really kind of physiologic cysts, meaning they can normally just occur. You know, they're just outpouchings of tissue. They are not problematic. You know, you'll see them sometimes on exam. You'll see them sometimes on ultrasound, but they're not problematic. They're nothing to be concerned about. They don't give you an increased risk of cancer, or they don't give you increased risk of abnormal pap smears or anything like that, or they don't, like, you know, help HPV spread. Any of those myths. They're just physiologic cysts that happen that are really not problematic unless they get really large and they can cause like some pain or issues like that. But I don't think I've seen maybe but a handful in the past decade that have been ever problematic. So it's not really nothing to worry about.
All right. Is there a BMI requirement for fibroid surgery?
No, there isn't. But you got to be careful about surgeons' comfort. Some people are not very comfortable operating on larger women, but there's no BMI requirement. I've done fibroid surgery on 400 plus pound women. So if your surgeon is comfortable, you know, to do it, then it's absolutely no requirement. Now, I won't lie to you and tell you it's not harder. Yes, it's more difficult the more you weigh to do surgery, but it's not a quote unquote required. It's not bariatric surgery, put it that way. Bariatric surgery, they want to have like a particular BMI or what have you, or at least to show that you're losing weight. But fibroid surgery, not the same way. Now, again, it's all about comfort. So if you're doing a laparoscopic surgery with a very high BMI, you know, the trocars are only like this long, right? Sometimes you got to get the longer trocars, but it becomes increasingly more difficult to get those trocars through the belly if you have a bunch of adipose or fat tissue to get through. But it really doesn't matter. You can still, you know, it's not a cutoff as far as weight for fibroid surgery or laparoscopic surgery for that matter. Case in point, if you watch my 600-pound life, what's my little man name? My surgeon. You know, you're so fat, you gotta lose weight or else. If you don't lose weight, you'll die. Like, dude, I love him to death. But if you notice, he gets his little ass up there. He gets his little ass up there on like just stacks of steps, and he does these surgeries. Like he does it laparoscopically. He's not opening them up. So that just shows you, like, you know, you could be 500 pounds to get laparoscopic surgery. Like, you just got to get the trocars in. That's all.
All right. What can a woman do if she constantly feels dryness after menopause, or is this an expectation you just have to deal with?
Excellent question. So question about dryness after menopause. This is called vaginal atrophy. So let me explain to you why that happens, right? So so the ovaries produce estrogen, progesterone. Estrogen is responsible for for lubrication of the vagina. Like it causes the tissues to be robust and to be vigorous. When you lose estrogen, the tissues become more frail. The vaginal tissues become more frail. They become more dry. That's typically what happens. You know, you got 3 types of women that go through menopause. One woman doesn't have any problems whatsoever. This is a minority. If you get 100 women, it may be 10 to 15 of them that have no hot flashes, no problems. It's just like they stop having periods, no issues at all. All right, that's one type of woman. Second type of woman is a woman that, like, she go through menopause, she'll start having periods, and then she will have a hot flash every few days or go through it, and it's like, you know, it's not a real problem, it's just annoying. May have a little bit of vaginal dryness, use some lube, and she's fine, not a problem. Doesn't really change her way of life, doesn't cause any problems, any issues. That is about, I would say, 70 to 80% of women have that. Or they may have it to where it's somewhat problematic, but there are certain things that could possibly be done. Then the third type of woman, horrible hot flashes. When she sleeps, she having hot flashes. When she outside, she having hot flashes. Can't have sex because of her vaginal tissues are just dry. Just can't move or maneuver without them, right? So that's about another maybe 10% of women that experience that. So everybody doesn't have vaginal dryness. Some women do, and the reason, again, is because of the lack of estrogen. So the 3 things that can be done, all right? You don't kill a shotgun with you don't kill an ant with a shotgun. You don't do the most difficult thing first, right? You start off with the simplest thing. The simplest thing would be to use lubricants, right? So there's different type of lubricants for vaginal dryness. Silicone-based lubricants are a little different than water-based lubricants. Silicone-based lubricants are really, really slick. It's like a drop, and it's like oil damn near, right? And they're not really messy. I recommend those as opposed to water-based lubricants, especially for older women. Sex can get all messy and problematic. You need all of this lube to do it. Silicone-based lubricants is like 2 or 3 drops, and it's a slip and slide, right? That's one way to do it if you just want to do something simple. If that's not working, there are medications, right, to help fix it. So Aspina is one that helps specifically for vaginal dryness in women that experience vaginal dryness, right? Then people will ask about hormone replacement therapy, like giving estrogen back. That is also another treatment option. You want to use that last because there are certain side effects that exist. But when you use vaginal estrogen, it's really not as high of a risk of side effects as if you take estrogen by mouth. So that will be the last line of treatment. That typically always works. So if a woman has intense vaginal dryness, then we would give a vaginal estrogen to help.
All right. I was told that the size of my fibroids wouldn't leave enough normal uterine tissue to hold a child. Is that true?
They lied to you. That's a lie. You have normal uterine tissue. Your fibroids do not completely. Now, I've had one case where a woman had cancer, and that was not the case. But if non-cancerous fibroid tissue, if you know what you're doing and you know anatomy,
that should not be the case. You should be able to remove fibroids and preserve uterine tissue. Now, again, you have to do your research on your surgeons, because I just had a really, really tough case to where by the time when I finished taking all of the fibroids out, it was like a bomb exploded on her uterus. So I had to really put things back very meticulous. If you just start sewing, and you don't know what you're doing, then you could sew the cavity up, you could sew tubes up, and you could remove fibroids and still make somebody infertile by not putting their anatomy back together appropriately. So if you put the anatomy back appropriately, you should be perfectly fine. And no, I've never seen it to where there's so many fibroids that there was no normal uterine tissue and you can't. You should be able to remove the fibroids and put the uterine tissue back together appropriately. So if somebody told you that, I would get a second opinion.
All right. If someone has ovarian cysts, would you recommend checking them out periodically?
No. All right, and I'm gonna tell you why. All right, so this is one of my biggest pet peeves about explaining ovarian cysts, right? Because this is, and I did a post on this, and people got all pissed off and up in arms, but this is how it goes, right? Every reproductive age woman, meaning that if you are having regular periods, has ovarian cyst at some point, right? Ovarian cyst, there are two different types of ovarian cysts, so I don't want you to mistake what I'm saying. One type is just physiologic, other type of pathologic. I'm going to explain the difference. The majority of ovarian cysts are physiologic, meaning in the middle of every month, your ovary is going to the one dominant egg, right, is going to mature, and their cyst is going to form. That cyst is going to then rupture, and an egg is released. I don't care who you are. If you're not on birth control, every woman is going to have that in a particular month. So if I scan or I ultrasound any reproductive age woman at the right time of the month, she'll have an ovarian cyst. It just is what it is. So a lot of times what I see, woman has pain, she goes to the emergency room, they can't figure out what the problem is, they do an ultrasound, they say you have ovarian cyst, and nobody explains it to her, and she takes that and runs with it and says, I have ovarian cysts. 90% of the time, they're physiologic. They're not pathologic. Now, pathologic cysts are different, right? So you can have something like a dermoid cyst, where it's like coming from embryologic tissue. So that's like when you hear somebody say, I had a cyst removed and it had teeth in it or hair in it. It's embryologic cells that can form into cysts, right? There are also things called hemorrhagic cysts. So women with endometriosis, they can have cysts that form with old blood, and they just really get big and swell with blood, and they rupture, and they get big. It's really no need to follow cysts with ultrasound unless they're pathologic and they're large and they're giving a patient pain or issues, and you're trying to determine if a patient needs surgery, right? Or if you're questioning if it's a cancer. So my older patients, if they have like a 3 or 4 centimeter cyst and there's some questionable findings on the ultrasound, and you have a question for if it's cancer or not, but we aren't ready to do surgery, you would follow that cyst out to make sure that it's not growing, at a abnormal rate, to make sure that it's not a cancer. That's the only way that you would have to do that. I say this all the time. You have to be careful. And somebody argued with me about this too, about just getting labs. My insurance paid for the labs. Why can't I have the labs? It's not like that. All right. So it's you can get labs and you can get things, and that makes you feel better or feel good, but it's about what is that information going to do. Anytime you get a lab, an ultrasound or whatever, you have to be prepared to do something about it. So let's say, for instance, you have a 4 centimeter cyst. When are we going to operate? When it's 5 centimeters? If we repeat it and now it's 6 centimeters? What if we repeat it into 7 centimeters? Or you repeat it into 8 centimeters? When are you going to say, okay, that's it, now let's go to surgery? There is no time to do that. So it makes no sense to continue to just monitor unless you are worried about a cancer or this is a determining factor for surgery. Other than that, you don't have to continue to monitor it. You actually look at the patient clinically. If you start to have pain, you start to have abnormal bleeding, you start to have pain with sex, those types of things are much more value to me than to sit there and ultrasound you every 3 months or ultrasound you every 6 months. Now, imagine if I tell you I'm going to give you an ultrasound every 3 months or 6 months, who's that benefiting? That's going to benefit my pockets. I can tell you I can get labs for you every 3 months. It's going to make my pockets get bigger. It's going to make me, if I ultrasound you every 6 months and I'm doing the ultrasound in office, I'm gonna get those reimbursements. So I can tell you, yeah, you need that, and make you think you need that. But at the end of the day, it's going to make me richer. It's not going to give me more information. And yeah, maybe your insurance may cover that. But what if I'm doing that to everybody? Everybody's insurance is not doing that. So for you saying that your insurance is saying, oh, I can pay for it, my insurance pays for it. What about the next person? So if I do you just like I do everybody else, somebody's going to get screwed because everybody doesn't have the same insurance plan. So if me as a physician, if I'm just making it my practice to do these chronic ultrasounds on every single person, I'm not getting any more information. I'm getting rich off of this stuff. And it's not doing anything. In fact, it'll probably hurt more people because now I'm going to start to do surgeries and intervene when I don't have to and do things that you don't really need to do. And then I'm going to cause a hardship on certain people because their insurance is not going to cover it. So now they got to come out of $300, $400, $500, or $600 out of pocket because I just choose to just serially do ultrasounds. It just doesn't make sense. And if I'm going to treat one person one way, I should treat all my patients the same way, right? Not because their insurance pay for it, just let me order it, right? I should treat you the same way I treat the next person. If I need it, absolutely, I need to order it. But if it's not needed and it's not going to give me any extra information, it shouldn't be ordered.
All right. If you suffer from PCOS, are there benefits to using the keto diet to reverse insulin resistance?
All right, so PCOS or polycystic ovarian syndrome. So let's first start off, and we could talk a little bit about what. Hey, everybody, just saying hello. So PCOS is a disease of insulin resistance. Now, mind you, we have a misconception that it only happens with larger women or overweight women. That's not the truth. So there are many women that are of normal size or even underweight that can have PCOS, which shows that weight is not the only issue with that disease. With that being said, for larger women, right, that is also a part of the disease in which adipose tissue or fat tissue actually produces estrogen. So PCOS is a disease in which there's an excess of estrogen. And that's because of the insulin resistance. So the cells of the body have a resistance to insulin. You're putting out a bunch of insulin, and there's high levels of insulin in the body, which can cause other hormones in the body to be off whack, which could cause your estrogen to be off whack. It could cause an increase in testosterone or male factor hormones. It could cause pretty much an imbalance of hormones. So for larger women, reducing the amount of fat or adipose tissue will help with PCOS. So as far as it's not the keto diet, but the diet in of itself and losing some of that adipose tissue. So whatever that diet is, whether it's keto, paleo, whatever diet that's out there that will help you with losing adipose tissue or losing fat will help with PCOS. So I wouldn't necessarily say any particular diet more than the other, but weight loss in of itself will help with PCOS.
All right. This is from the comments on the screen.
Right.
Does the depot shot work as a first treatment for fibroids?
No, it doesn't. So depot shot can cause, it can help with the bleeding, right? But this is the misconception about fibroids. And everybody thinks that, well, if I don't eat meat, or if I work out, or if I just cut off all the processed food in my diet, my fibroids are going to shrink. This is false. those things will help you with your general health. So you should be doing that anyway, right? They will help you, you know, with your heart health, with your, you know, with your weight and those types of things that make you a healthier individual. They will not just shrink the fibroids, right? The same way with hormone suppressions or medications, right? So Depo can help you with bleeding. It's not going to shrink the fibroids. Lupron, which is pretty much a medication that shuts off the ovaries, can show some decreases in fibroid size, but the problem, it's smoke and mirrors. While you're on it, it can cause the fibroids to decrease in size. You can't be on them for more. It can't be on it for more than a year to 18 months. So once you come off of it, it's going to regenerate. I mean, it's not regenerate, but it's going to gain in size right back. So it's smoke and mirrors. It's not something that you can get on and just eradicate the fibroids. And then there's, you know, major side effects to Lupron, including like menopausal type symptoms, because it's really shutting your ovaries down. So they're really no medications that are going to decrease the size that you can use long term, and there's really no diet or activity level. The truth of the matter is, which nobody wants to hear, is that we don't know, right? I know that's hard. It's hard for people to accept when we just say we don't know. You got to have an answer. Everybody has to have an answer. It's like, oh, it has to have this. Oh, it has to have it. It has to be an answer. There isn't. If it was, I promise you, I would tell you. There's been, and the reason why, again, I can tell you anything, right? As a person that is not in, you know, it's typically somebody who's never treated a patient for fibroid. That has never studied fibroids, that has never held a fibroid in their hand, is going to tell you that these magical pills are going to make your fibroid shrink. Give me $30, I'm going to send you these pills and watch your fibroid shrink. And then you'll have a couple of people, girl, my fibroid shrink. I got an ultrasound and it was 5 centimeters, and somebody said it was 4 centimeters with the next one. Good Lord, God be the glory. No, it's not that way. It's just not, okay? Let me tell you the thing about ultrasounds, right? If I get one person that does an ultrasound today, and then I get another person that does an ultrasound in a week, 2 different sonographers are never going to have the exact same result. This sonographer may have a 5 centimeter fibroid just by the way they hold the probe. The next one may have a 4.3 centimeter fibroid just by the way they hold the probe and how the radiologist interprets it. That doesn't mean your fibroid shrunk. I'm sorry, it just doesn't. All right, it's just user difference. That's it. But people will argue me up and down like this is it. Take it from somebody that actually has fibroids in their hands multiple times a week, hundreds and thousands of times over the past decade. I know these things. Like, I can just tell you, it just doesn't happen the way that people think it happens. And they want to argue with me, but you can't argue with somebody that actually, I mean, I don't know a lot. I promise. I'm not an expert on everything. But this shit right here, I am. All right. This is the one thing that I can say that I know more than 99.9% of the country. All right. This one particular thing. Now, I can't argue everything else, but when it comes to this, nobody can really argue with me about fibroids because I do this all the time. So when y'all come in the comment section and like come in my DMs, want to argue with me and give me these damn articles and look at this person said about fibroids, kiss my ass, okay? Like, I don't care. Like, I this is what I do. This part you cannot argue with me about. There's other stuff you can argue with me, not this. This is not. So if you really want to know about fibroids and you want the truth, I am not going to lie to you. I am not out here trying to, somebody said I'm out here trying to just snatch women's uteruses out. Like, get the hell out of here, okay? Like, I've seen 10 people in the past 2 weeks, and all of them, I've told them, look, if you have a purpose for your uterus, and I have a 50-year-old woman right now that just consulted with me a couple of days ago that wants her uterus and has no purpose for it, I tell her, if you have no purpose for your uterus, you might want to, you're just going to hang on to it for no reason. All right, I'm going to do a post on this really soon. And this is my next post. The only purpose for your uterus is to have babies. That's it. There is no other purpose for your uterus. That is it. It bleeds and it gets prepared for pregnancy. That is the entire purpose for your uterus. If you don't have that purpose for it, to have a child in it, and you are suffering from fibroids that are pushing into the cavity, that are just distorting your uterus, that are causing your pain, you may want to, I'm not telling you to get a hysterectomy, but don't take it off the table, because otherwise, if you do anything else, if you keep your uterus and you preserve your uterus and you don't have any other thing to do with it, realize that it can continue to be a problem.
Yeah.
Period. It can continue to be a problem. And if you're okay with just having a problem, keep it. But what I would tell my own mama, I tell anybody, like I talk to you like I would talk to my own mama, my own sister, my own cousin. Like I talk to everybody that way. I'm not going to do anything to anybody that I wouldn't do to my own family. And I would tell them the same thing, that if you don't have a purpose for your uterus and you have serious, significant fibroid disease, at least listen to hysterectomy. Now, I'm not saying get an open. I don't agree with open hysterectomies. Everybody should have a laparoscopic hysterectomy. I mean, has the ability to have a laparoscopic hysterectomy. Am I right?
Yeah, I was kind of extreme.
Correct, right?
We just don't. We ain't got to talk about that part.
Cases, but
it ain't my
I will give everybody the opportunity to have a laparoscopic surgery. If somebody's telling you they need to open you, get a second opinion. But don't take it off the table, right? That's all I tell you. Just don't take it off the table. Leave all your options on the table. But if you're 50 and you want to try one more time for IVF and you got fibroids, I don't give a damn. Let's take the fibroids out, keep your uterus, go for it, mama. Shoot for the stars. That's cool. But if you don't, at least leave it on the table.
I can at least attest in the last September, October, November, December, January, going on February, I have not missed my uterus one single night at all. Period.
There's not a hormone imbalance after hysterectomy. No, your ovaries control hormones. You can have a hysterectomy, keep your ovaries, and you're not going to have an imbalance, right? It's not truly an imbalance anyway. Menopausal women don't have an imbalance. It's just a bad terminology. Hormone imbalance is not true. You can have a decrease in estrogen, decrease in progesterone, but it's not an imbalance. It doesn't throw your body off whack. But as long as you have ovaries, you will continue to produce hormones. You don't need a uterus. The only way you need to use it to keep your uterus, or the only purpose for your uterus, is to get pregnant. That's it. That's all. There's nothing else. If you're not trying to get pregnant and you're suffering from horrible fibroid disease, just keep all your options open. That's all I'm saying. People with fibroids can also have other procedures. You could have an endometrial ablation as long as the fibroids are not pushing into the cavity. There are other options. So I'm not saying that fibroids mean hysterectomy. It doesn't. But realize that as long as you have a uterus, you can still have bleeding, you can still have fibroids, you can still have pain. So if you want to be done, really, leave all options on the table.
Yep.
Hold up. Yeah. Hysterectomy risk with scar tissue on colon and abdominal cavity? No. If you do a laparoscopic or robotic surgery, you should not have a ton of scar tissue. But scar tissue happens from surgery. Anytime you stick a tool or cut the belly open, you can have scar tissue that forms. It's one of those things. Like if you fall off your bike, you get a wound, right? That wound is going to get like a watery kind of discharge, and then it gets a scab. Well, the same thing happens to your belly, inside your belly. When you cut on things, it does the exact same thing. Scar forms, and then it forms scar tissue. Some people form more scar tissue than others. I will say this. Talk to your surgeon extensively about their practice and how they do things. If you don't do excessive cutting and you put things together back appropriately, then it reduces the formation of scar tissue. Give me 1 second. Let me answer this for you.
Okay.
Yes, ma'am. I'm good. Uh-huh. Let her go. That's fine. All right. All right, baby. My bad.
No, you're okay.
But yeah, so that's that's that.
All right, next question. This
How
was
young is too young for a hysterectomy? My daughter's swimming with severe cramps and vomiting. She refuses to get an exam. Any suggestions? At 21, she doesn't need a hysterectomy. If she has severe cramps and vomiting, there are other treatment options. DM me, we could talk about it, but she doesn't need a hysterectomy. It's very rare that somebody needs that for that young. I've had it. I've experienced it with patients, but usually there's another option. All right, I'm sorry. Get back to it. I'm off track.
You want to read the screen or you
No,
want me?
I'm not. I just saw that. It just popped up to me. I'm not
Yeah,
looking at
no,
it.
I know people can send you one in the question box themselves. So I'm going through those too, but I'm going back and forth. All right. If your labia causes you discomfort, i.e. one side is larger, is the only procedure cosmetic as to where insurance won't assist?
That's a sticky one. So if it's caused by like a Bartholin cyst, then your insurance will cover it, right? If you just got, all right, now y'all know I talk like we at the like we outside. Now if you got like the curtains or the drapes, right? If you got the drapes and you don't like your drapes and it just looks like abnormal, you mad because your curtains ain't right, then yeah, that's cosmetic, right? That's just total cosmetic because there's nothing really wrong with you. There's not a pathologic disease. You just don't like the way it looks, and it's not hurting you. Then yeah, that's cosmetic. But typically, like pathologic things like abscesses or Bartholin's gland cysts, those can be explained and covered by insurance. It really just kind of depends on what you have. But if you just looking like, one side just ain't right. It's just like having this little flab right here. I just don't like it. It's one of those things. Like if you don't really like it, you're gonna have to pay for that one. The insurances ain't going. Somebody asked about like, do you need if fibroids are not causing any issues, should you get them removed? No. If they're not causing any problems, leave them alone. Unless they are extremely large, very large. Like you should start thinking about it. If they're like 10 centimeters or better, you should maybe think about it. But other than that, if it's not causing you bleeding, pain, no pain with intercourse, anything like that, you don't necessarily have to do anything. 80% of Black women have fibroids. Only 25% of them anything about your fibroids.
All right. My menstrual cycle is shorter and darker as I get into my 40s. Is it my fibroids, my age, or both?
It is your age. It is your age. So every woman has a shelf life of her ovaries, right? Your ovaries don't last for your entire life. That's what menopause is. So menopause is the decline of your ovaries. From the time you have your first period, you are on a clock, right? Your ovaries are going to start to lose production the older you get. As you get older, and you start to lose production of hormone in your ovaries, it will cause your periods to become abnormal. Why is that? Because you don't ovulate appropriately or regularly anymore. When you start to do that, you don't have regular periods anymore. So your periods can become a little darker. They can become more spaced out. They can become even excessive, where you have more excessive bleeding. All of those things can happen, and that is directly associated with age. Fibroid bleeding typically causes heavy bleeding or excessive bleeding. It doesn't really cause like discolored bleeding unless you just have, horrible, cramping, or you just have like a decrease in the outflow of your blood to where it's just sitting there pooling. But that's the only way fibroids can really do it. But if you're getting older and you 40 plus, it is more associated with your age as it is fibroids.
All right.
What conditions cause excessive bleeding other than fibroids? There are a trillion of them. Endometriosis, adenomyosis, physiologic abnormal uterine bleeding, uterine polyps, cervical polyps. Like there's a ton of other different things that could cause excessive bleeding other than fibroids.
All right. What about bladder prolapse or loss of sexual sensation from not having a cervix?
No, false. So that was an old thought. You know, before we did studies on it, we used to believe that that the pelvic floor was dependent on the cervix and the uterus to be intact, and that women that had hysterectomies with removal of their cervix had an increased risk of prolapse. After studies and studies extensively of it, we found that that is not the case. That women with hysterectomies, now, and another thing, I'm going to do another post on this too, because I keep jumping off on topics because I hear about crazy stuff all the time. All right, let's dispel this. Complete and partial hysterectomies. It is not a thing, okay? This is not a thing. And I'm going to finish my point about the prolapse in a second, but I just jumped off on another tangent while I saw my brain. Complete and partial hysterectomy. A hysterectomy is a hysterectomy, period. A subtotal or a total hysterectomy means removal of the uterus with the cervix or removal of the uterus and the cervix. That's a total hysterectomy. Subtotal means just removal of the uterus, keep the cervix. We don't do that anymore, right? Which goes back into the other point. You don't need your cervix for anything. The only time I ever do a supracervical hysterectomy or a subtotal hysterectomy is when a woman does have prolapse. When she does have prolapse, then I can use the cervix to do suspension procedures to help correct the prolapse. Other than that, you do not need your cervix, right? With that being said, you know, the question of like when you remove your cervix, what happens? Nothing, right? Your pelvic floor still remains intact. It does not lead to prolapse. Now, prolapse, or when your tissues of your vagina actually sink in, and it can be sunk in from your uterus, or it can be sunk in from your bladder, or sunk in from your bowel, like those, that it's multifactorial of why that can happen. One is age. The older you get, the higher the incidence of prolapse. One is genetics, right? So if your mama, your grandma, your aunties, like they have prolapse, it's a more high likely chance that you will have prolapse. And that's because it's connective tissue, right? It's a connective tissue disease. So, you know, the same reason why, you know, some people are double jointed and can move their arms and hands and stuff back is their connective tissue. Same way with the connective tissue of the pelvic floor. It's the same reason why some women, they could get one incision, the next woman can get the same incision. One of them a keloid, the other one won't. They have different connective tissue, different properties of their skin, right? So that's another thing that could cause it. Chronic lifting, right? So my mail worker, my postal workers, my CNAs, my construction workers, those women that lift chronically heavy things have a higher incidence of having prolapse than other women. Other things, smokers. So women that smoke, you can have chronic cough. Those women are higher risk, and they can also weaken the tissues. Those women also have a higher incidence or higher risk of prolapse. There's another one. Oh, so vaginal deliveries is another one. So it's not the only thing. Now notice I said it's one component. So I have women that have had 5, 6, 7 vaginal deliveries, absolutely no prolapse. I have women that have 1 vaginal delivery with horrible prolapse. So it doesn't matter, yes, but it also are all of those other things that I just mentioned. All of those things, including environmental factors, all of those things mixed in will be the reason why or why not you develop a prolapse. It has absolutely nothing to do with whether you remove your uterus and your cervix. It's all of those other things that I mentioned.
And someone said in the comments, would you still have a G-spot without the cervix?
Absolutely. Your G-spot is not located on your cervix. Your G-spot is on the top part of your vagina, about 2 centimeters back from your urethra, or where you pee from. So if you take where you pee from and you put your finger back there about halfway, that's your G-spot. We'll talk about that later.
All right.
Go ahead.
Can the location of your fibroids cause issues with your kidneys or issues with passing feces?
They have to be extremely large, right? So it wouldn't happen with your kidneys, but they can happen with your ureters, right? So your ureters are the tubes that go from your kidneys. So your kidneys are located on the sides in the middle of your back. So they're not in the front, they're in the back, right in the middle, off to the side, right? So from your kidneys, they have tubes that go from your kidneys all the way down up over to your bladder and then out of your urethra where you see pee from. If fibroids are extremely large, they can impinge on those tubes that you urine. I did have one patient that's really in my mind that's how I met her. Her fibroids were so large they were pushing on her ureter, and it was causing a hydronephrosis, which means the pee was going back up into her kidney because it couldn't go down to her bladder because her fibroids are too big. So it's not causing a kidney problem, but it's causing a ureteral constriction. And with that being said, you still got to have a really, really, really large fibroid to be able to do that. Nothing less than 10 centimeters is going to cause that. Even 10 centimeters is not going to do that. You need to have a huge fibroid that's going to cause constriction of your ureters. What else did they ask about? About the size?
Passing feces.
Yes. So it can cause constipation, but again, it's a huge fibroid that will cause constipation or chronic constipation. And that's, I don't see that very often. It's very rare that I see that.
Okay, I'm gonna go back to one that was submitted in before the live. I have a hairline incision from fibroid surgery. When I had my child, they reopened the same incision for an emergency C-section. Mm-hmm. My son is almost 4, but I still feel tenderness at my incision, and it seems like it's slightly keloid. Is there any prescription cream that can make that feel better or look better?
To feel better, not really. So when you cut into the skin there, you can cause numbness or like chronic numbness because you're cutting into the superficial nerves or the skin nerves that are there, and some of them don't regenerate. Like just like right now, I cut the tip of my finger off. You can't really see because it's like it looks normal, but I can't feel the tip of my thumb. Like it feels weird. But the tip of my thumb, I can't feel it. And that's because I severed the nerves at the tip of my thumb. So where now it's just going to be chronically numb, where I don't feel much feeling there. And that's the same thing that happens in your belly. So as far as the feeling goes, there's nothing really you could do. But the keloid scar or what have you is something you can do. So you can inject that with a low potency steroid and inject that, and you can flatten the keloid scar out. Talk to your doctor. If your gynecologist is not comfortable or your family doctor is not comfortable doing it, dermatologist will definitely be comfortable and will give you the option to do that. That's always an option to be able to inject it with steroid to flatten it out.
All right. In a previous video, you said even if you take the insurance, the hospital may not. How Correct. Would we know what insurance the hospital will take?
So that's on the office, right? So for instance, for me, if a patient sees me, then we would do the consultation, go through the whole thing, and then if we decide on surgery, then my office will check and make sure that it's okay with the hospital and it's okay with your insurance company. So the office in which you are going to should be able to determine that. It's very rare for a hospital not to accept insurance. Meridian, which is one of the public aid MCOs that I'm thinking about, is the only insurance that sticks out in my mind that my hospital doesn't accept. But for the most part, the hospital will accept mostly all insurance. The question becomes is, will your insurance pay for the hospital? Is that relationship there? So that is a bigger question. You can call your insurance company and find out ahead of time if they cover the particular doctor that you're looking for, and if that doctor is within your network, and if the hospital that that doctor operates from, if they are in network as well. I get comments and questions all the time, and this is a little bit off topic, where they're like, well, can you come to my my city or my state and do my surgery? No. Okay, the answer to that is no. And the reason being, I'm not the traveling surgeon. I'm not, people come here to me for surgery, and that's not to be conceited or whatever, but I'm not flying out to do consultations and surgeries or whatever. And that's for a couple of different reasons. If I could, I would try to heal everybody and do everything, but I cannot do that. And one reason that I can't do that is because wherever I go, like when you guys see me post stuff about me teaching surgeries, notice I'm teaching. You don't see me actually doing the surgery. So I have the ability to go wherever state and teach surgeons the equipment and teach them different surgeries. I can't actually perform the surgery in that state because I have to be licensed in every state that I operate on, and then two, I have to be credentialed in every hospital that I operate in. So I can't even perform surgery in every hospital in Illinois. Right, I'm only really on credentialing on staff with 2 hospitals here in Chicago, right? And that's so I can't operate at every hospital. I have to be credentialed at that hospital to perform surgeries and to see patients. So you can't just go to a hospital and operate. Like, it's just a misconception. That physician has to be credentialed at whatever hospital they're operating at. So that's why you can't just go and just do surgeries or whatever everywhere.
All right. This is in the chat. What are the risks of surgery to remove fibroids with adhesions that are attached to colon, abdomen?
You can get into, so there's a risk to every surgery. One risk is you can have injury to things. So you can have injury to your bowel, the bladder, the ureters. All of those things can be injured. So if your colon is significantly attached to your uterus, then if you try to pry the colon off of the uterus, you can tear the colon, right? So that is a risk. So if you do have significant adhesive disease, you definitely want to get with a surgeon that is skilled and experienced at taking down adhesions, right? So I don't care how skilled and how experienced you are, the risk still is there, but the risk is minimized when somebody knows what the hell they're doing, right? You wouldn't go, get your wig, your weave, your eyelashes done by me, right? Because I have no experience, right? You're going to go to somebody to know what the hell they're doing. It might be all right, but then again, you might lose all your hair too if if you go to somebody that don't know what they're doing. Same way with surgery. Like you want to have these conversations. If you have multiple surgeries in the past and you have adhesions, you don't want to just go to Joe Schmo. You want to have that conversation as far as what their experience and comfort level with adhesions are. I got a patient right now that's supposed to come up here for surgery. She's in one of the southern states. And I've never heard this, like, pisses me off. Like, she had surgery 2 months ago and the surgeon cut her went into to do a myomectomy, cut her, looked at her uterus and said, I can't do it. Fibroids are too bad, and closed her back up. Literally did a big incision, everything, and didn't touch one fibroid. And now she's trying to heal from this surgery and actually get her surgery done. But instead of the surgeon being like, you know what, I'm not comfortable doing these things or whatever, and I just don't have that experience or skill, they went and tried it anyway. So I say this to people, like, really, really, really grill your surgeon. Like, you have to have a trust level of that person's experience and how they feel about dealing with your particular case before you trust them with having surgery. And that's okay. Even when I have a million questions, I don't really get mad about someone asking me questions or really being cautious, because it's a big deal. And as skilled as I am and as much as I know for them, they don't really know me like that, and they have to be comfortable. So you can't really get mad at somebody, who's trying to gain comfort with who you are and what your skill level is. So don't be afraid to ask questions. Like, before you get into these things, like, you have to feel that comfort that that person is going to treat you like they would treat their own mama. And if you don't feel that, never agree to surgery. And you continue to look for a surgery until you feel that comfort level with that person. Because literally, if that person gets back there and they get frustrated or confused or have an issue or whatever, that could be major issues for you. So make sure not only do you talk to them and find the comfort level with them, but also talk to people who they operate on. Look at their success rate. Like, look, are they patients really talking about them, and talking about them in a good light? Or have they had complicated patients that they got? Like, ask them, like, how many patients have you had with, 30 fibroids and 15 centimeter fibroids that you've operated on? Can I talk to some of them or whatever? Like, I have absolutely no problem. I will reach out to patients that I've operated on, if a patient is uncomfortable, and try to link them so that they can talk and have those conversations. I don't think you got to have the right person and the right patients to do that. But I think a majority of my patients feel comfortable enough to make somebody else feel at ease if they need to feel at ease. So don't be afraid to ask them, can I talk to one of your patients, to be able to, ask them some questions, right? And see how their experience was.
I agree with that. All right. This one is in the chat as well. Is it normal for a cyst on the uterus 2.5 centimeters to leak and cause pain for over 3 months?
No, it's not going to leak and cause pain for over 3 months. Now, remember, I'll talk about a physiologic cyst. That sounds like a physiologic cyst, and that cyst will rupture, right? It will rupture and will release an egg. Sometimes that could be painful, but that pain only lasts for, 2 or 3 days maximum. If you haven't consistent pain for 2, 3, 4 months, then it's something more than that small cyst. A 2.5 centimeter cyst should not give you that type of pain at all. It's something else that's causing you pain other than that cyst. For a cyst to really, you don't even really start thinking about cysts causing pain until they're 5 centimeters or better. And even 5 centimeters is small. But anything less than 5 centimeters should not cause significant pain. Even pathologic cysts that are 5 centimeters, unless they're like a metastatic cancer, should cause any extensive pain like that.
Okay, we do have a lot of questions, but we get into our hour time limit, and
But that means they got to come back.
Yeah, Instagram be acting a fool. So we didn't get to intro because I couldn't get in the chat because somebody wouldn't let me in. Somebody wouldn't let me in.
That's like, all right, what up?
But if you've been here before, we try to do this regularly. We trying to do it once a month. Definitely feel free to submit questions to me. I know some people DM you directly. Some people DM me directly.
Nah, DM Cola. Like she is the gatekeeper of the questions.
Yeah, I try to go over it every 4 weeks, and then I go through. If it was duplicated, it may not be worded exactly how you said it because somebody else asked the same thing, but I try to get the common things. I don't do the personal questions.
Right.
But maybe one day we'll get Dr. P to answer a fun question for us. Okay, y'all?
We can do it. I'll talk, sex question. Like we doing on Saturday, I'm doing a whole forum about like orgasms and sex and all that other stuff. So I do it all. But please don't DM me, email me with your whole history and want me to ask these questions. I'm not doing that. I am not. If you would like some consultation time, I will look at your whole history and your ultrasound and all that stuff. We can have that whole setup. But I am not reading everything and being just your personal doctor. I'm just not doing that. Like I have time limitations. So if you want that, you can definitely set it up. Go for docforthestreets.com, set up a consultation time, but please do not DM me all your whole personal history because I'm just like, I made 1 or 2 word answer you, so don't get mad. But if you want consultation time, please set that up. But this is free. All this is free. Tune in. You can have free questions right here. Like, here it is. You have a question, ask it, and I'll answer it. No problem.
Yeah, so we try to get to everybody we can. We get a time limit. And like I said, I try to keep it limited to health questions, even sexual health questions. I get personal, like height, what did he do with his hair? I get a whole bunch of different questions. I leave those out.
I get into these moods. Like, I'm about to do some more real drastic stuff. Y'all about to see. Like, I'm in this mood, so like I'm about to do something really, really drastic that's gonna make my mama cringe.
I didn't change my hair every live. Nobody asked me anything. No.
What you do to your hair? No.
I changed it.
But I do drastic stuff. Sometimes I wake up and I just like, you know, that's it. Like, you know, no more mohawk. And I'm going to do I'm about to do something real drastic though. I got an idea that I want to do something, and I'm going to do it really soon.
Okay. Well, we'll debut it at the next one. Okay.
Yeah.
If I got y'all. I'm taking care of the people. All right, well, Doc, we really appreciate it. Thank you for your time as always, and we really appreciate all your help.
What Dr. Who said? What happened?
That's my daughter in the background saying thank you.
Tell her hey.
He said hey, music. All right.
How do you set your robot in a 15-week uterus? So how do I set my robot, or how do I'm assuming you're asking how do I put the camera in? Unless the fibroid or the uterus is past the umbilicus, I'm always going through the umbilicus from my camera. Always. Like I can manipulate. That's really negligible. So if I could just get a camera in there and it's not touching my specimen, then I'm cool. So that's how I do it. The rest of my arms, like, I'm just right there. Like with Cola's was different. I couldn't put anything by her belly button. Like everything, like I put ports damn near by her diaphragm. Like literally, like I had to put her trocar. If y'all look at her incisions, like they are damn near where she breathed at. And even then, when I put them in, like I literally had this much room from the end of my trocar and the top of her fibroids. So it really just depends on how high things are. You want to stay above it, but if you don't have room to really put it in there, you in trouble. But I keep everything at the umbilicus until I can't. And then I have to go up to do my surgery. All right, that was the last one. It was just
and you did all of that with me having a short torso because I was worried about that. So
it was challenging, but we got through it, Mama.
We sure did. Yes. I feel great. All right. Absolutely. Well, until the next time, like I said, I'll keep it all organized and I'll let you know when 4 weeks come up again.
Sounds like a plan. So y'all send y'all questions to her. We will do this monthly. If it gets like crazy, then we'll do it more than that. We'll do it, every few weeks or whatever. But, for now, we'll do it like at the beginning of every month.
And I do put it on YouTube after. So people who say, I don't have social media, I don't have Instagram, everybody can go on YouTube. You don't even have to have an account. If you want to like it, you do. But if you just want to watch it, anybody can go on YouTube. So I will put that up in the next couple of business days.
Sounds like a plan, Mama. I'll talk to you soon.
Thank you.
All right.
Have a good one.
All
Bye-bye.
Right. Everybody
Thanks, everybody.